this to you a little bit and ask you what do you feel like you do best as a PT?
Well, I think Justine stole some of mine. I was gonna say empathy, and the reason why is because we take continuing education when it comes to improving our ability to do therapeutic exercise and progress people correctly, and we do continuing education to be good at our manual skills and things like that. And as we've gotten better and better at that, we've become more technical. But it really doesn't matter what you're good at when it comes to therapeutic exercise and manual therapy if you don't have the empathy to understand where they're coming from. And if you don't know where they're coming from and you don't really address that first, then your outcomes aren't going to be ever as good as you think they could be, no matter how good you are technically.
Tell us why. Why do you think that is?
Well, because there are a lot of different ways in physical therapy to, for lack of a better term, skin a cat. So you have strain counter strain, you have manual therapy with joint manipulations, you have myofascial release, you have craniosacral therapy, and all of them can get really good results for different people. Everything works once, for every patient, everything works once. Not every patient, I said that wrong, but things will work for every patient, and other things won't. So you need to be able to listen to them, to try to understand where they're coming from in order to choose the technique that will work best. If that makes sense.
Even if they at times may know of some technique, or they may know, cranial sacral therapy.
Yeah.
They may want to have that. A friend of theirs may have said that's the best thing. But if it's not necessarily the appropriate one for them, you still have to be able to tune into what's going on with them.
Yeah, and another part about listening and being empathetic is the fact that if you tune into that, the fact that they do like craniosacral therapy, and that's something that you do practice, then the important part is that you actually then say, okay, we'll try a few things, and then in the back of your mind, if there's some other things that you want to try, then after a while say, okay, we've done those things, let's try something new and see if you like this as well. And that's really where, again, you're good at all these technical skills,
right,
but you get even better by understanding and establishing what the patient likes and what's going to be their best response.
Yeah. Both of you, I'll ask this question too. What was helpful for you guys at LifeWorks? You worked with a lot of really heavy-duty pain clients, people that were, complex, very difficult. What was helpful for you with those kind of patients? You get to go first.
Okay, I'll go first. So I think the most important thing that we started out doing was, for every patient that came in, we filled out a functional assessment called the Fear Avoidance Belief Questionnaire, or FABQ. And what that did was it identified patients who are in a realm for high fear. And that can be high fear for work activities or physical activities outside of work. And the important thing with that is, once we actually calculated it up, we could identify people who were in that high fear category just to start, which immediately changed the way that I started my objective and subjective examination with the patient during that initial evaluation. So we might spend more time on just education about what their condition is, or what things are good to do and what things aren't, than someone who is not in that high fear realm and really willing to get back and do the things they need to do, and maybe have a little bit more understanding about their pain.
And this is fear of movement, fear of pain?
Yeah.
So it's all pain?
It can be, it's more pain driven. So people who think that they need to stay in bed all the time because once they do any kind of movement, it starts hurting.
Right.
And we know from evidence that that's actually the complete opposite of what we want our patients to do.
So that's what my trainer says.
Yes, exactly.
Do you want to answer that question?
So I think the FABQ is definitely a strong part. I also think something that is even beneficial that we still do here is we have time. And one thing that I have worked on in other clinics is that they would limit patients to maybe 8 visits, or they would see them a ton and then they would just drop off. One thing that I really liked was that you were able to spend 40 minutes to an hour, and still are able, and we're able to base your plan of care based on every single patient in terms of, for instance, I saw one individual for over a year and a half, which in most PT cases, at least that I know of, they wouldn't necessarily follow through with. They would either try to push them to another provider, or they would say, you know, or they wouldn't be able to maybe find the progress that they're really making. So it gave us time for a graded exposure, if you will, for those high fear avoidance, chronic pain patients to kind of get back into the lifestyle that they want to do. You can't always just, you know, jump up onto the horse again.
Right.
So.
Well, I think too, just to piggyback that, and also kind of talk about physical therapy in the realms of how other people are seeing patients, which might be 15 to 30 minute time frames. The nice thing about getting good at something like motivational interviewing or identifying fear is that even if you do have that short window of time, you still have an opportunity to talk to them about their symptoms and what they're experiencing. Especially if you're doing manual therapy, or it's going to be, let's say, cross-friction massage or anything like that where you have time with them, you can talk with them while that happens. And if you're doing that, then you're addressing those fears, and you're still doing it within a reasonable amount of time. So people with really, really chronic conditions that have failed conservative management in the, before, and then they came to us at Life's Work Physical Therapy, those people needed some more time. And there, I'm sure, are patients that you as other physical therapists see, and you don't have that time that we had. That still doesn't mean you can't do this, and you still can't improve those outcomes.
Yeah. What do you recall most recall about learning MI? The MI stuff we learned from your class, or you learned from your class, hopefully.
So I think the thing that I most recall was that it's difficult. It's difficult to.
We'll edit that out.
Yeah. Well, it
is difficult.
Yeah, at the first part, it's not something that, when you look at it and you look at the basic concepts of it, like reflective listening and affirmations and open-ended questions and just listening with empathy, you hear those things and you say, okay, those are things
I can do that.
Yeah, I can do that. That's easy. And really, when you start to practice it, it is it's a skill.
Yeah.
And you need to get better and better at it. And what you'll notice is once you start to really pay attention to those things and then look at really good clinical physical therapists, you'll see that they're already doing those things. And
naturally.
They're naturally doing it. They're not thinking about it.
Right.
And sometimes that just takes time. But I think that practicing it and going to coursework about motivational interviewing just helps you put you on that accelerated level.
You just said you really talked about ORs just now: the open-ended question, the affirmations, the reflective listening, the summaries. What other things do you remember at all about MI from the class, if anything?
Well, I definitely remember. The things I remember the most, honestly, are when we were talking, and you were talking back to us and using those open-ended questions as we were trying to talk to you as a patient.
As a patient, yeah.
Yeah, and I remember doing our class projects, and then addressing those issues where a patient is not just a patient, it might even be a clinic where you're trying to change the idea of where the clinic is going, where they're not using any of those ORs, and then you're trying to change the concept. I think those are the biggest things that I really, really remember that stand out.
So practice, but having somebody else show you how to do it in some ways and practice it, okay? If you think back on the stuff with MI, what was not helpful or least helpful in the way we kind of did it?
Well, I think that it's difficult to say because this is the issue that we have when it comes to, I think, physical therapy as a whole. We go through 3 years of school, and at least in
intense years.
Yeah, intense years. And by the time that we're done and we're finishing up our 3rd year, we start to finally have the psychology class of physical therapy and doing this motivational interviewing. And so we have been drilled on differential diagnosis, and basically there's always kind of a root cause for a musculoskeletal condition. And sometimes that's not true, but if you don't, there are times when chronic pain becomes something that's not tissue-based anymore. It's not a mechanical issue. It's more of a heightened sympathetic nervous system. And unless you've had practice in that, then you as a student really don't quite understand that
Yeah.
concept.
Interesting.
So I think that the biggest problem wasn't the fact of how it was taught, it's actually that we don't get this introduction sooner. And it would have to be something, maybe just a little bit of education as a first year, and then coming back to it as maybe a third year student. I think that is more important, because I don't know if.
Yeah, that's a really good point,
I don't
because
know if people
part of
realize.
the issue is, as a first year, you don't have really any responsibility for patients. As a second year, we timed it, so it's got to be afterwards. We did it your class, you guys had already been on your second rotation?
Yeah, we had done.
So that we did
We've
one
done-
class that had only been on one rotation. They were like, this is easy. We don't have any problems. I had a person last year that said, did we do the clinical character thing with you where you wrote down a really difficult patient? I don't think we were doing
I
that
don't
yet.
think we did it yet.
This young woman said, I don't think I've ever had a difficult patient. I don't think it's ever been hard. Like, that's crazy. What have you been doing in life?
Yeah, and even when you're doing your rotations, you usually have a clinical
Right,
instructor
exactly.
that you can fall back on.
Exactly. So maybe titrating the thing throughout.
Mhm.
Yeah, I'd like to do it as a workshop.
Yeah.
In each year in some ways. I've also run the idea by him at times of doing, he's retiring, by the way, next year.
Oh, is he really?
Yeah.
No.
Yeah.
Dr. Rutt, what's he gonna do?
I don't know. He's just going to hang out. But of doing it in a way that would be leading to a certificate in some ways. So you could get a PT and MI certificate. So.
Actually, I like that.
Yeah.
I think that.
Oh, well, people would do it then, because in some ways, otherwise, it's not. It's in some ways it's like a complete add-on, and some people are really into it, and then some people, feel like, oh, geez, it's not going to count for the test, so who cares?
Well, no, but there's a thing about it, because I will probably be the first one to admit that I don't know if I was really that into it to start.
Yeah.
Because I felt like I was pretty good at that.
You
in
were
the
pretty
first
good
place.
about it too. Your dad's a counselor, and
Yeah.
so you had a lot of natural skill.
But then the problem was that I got into this group, and I was realizing that I was still not getting the outcomes that I wanted, and so to go back to something that I knew worked, or at least that I had a
Right.
book about, that was the
Inertia,
most
sort
important
of.
thing.
I'm going to go back to what I've been trained in.
Yeah,
Yeah.
And then I had a book, I had a resource, right?
Right.
And that was big, because then I could just flip through a couple things and be like, okay, let's try this with this patient. Now
Right.
I know the patient that I want to work on.
Right.
Once I have that patient in my mind, then I can practice it.
Right.
So I'd say that's one of the things I took.
If you think back and you would give people that are in the training for MI, or just really to engage with people, because that's really what we're talking about, what is a tool or a tip that you'd recommend to people that are training or becoming new PTs?
I think the biggest thing that you should always do with the patient, even though it takes time, is discuss the goals that you set with them.
Mm.
Because what happens is we have to do all of our goal objectives in our notes, but sometimes we don't actually tell the patient what we want to get from those.
What's
and
your
where they-
goals versus what's their goals? right?
Yes, and
The
where we
treatment
see
goals
them.
that you have as a professional versus their goals.
Absolutely.
Yeah.
And I don't think we always discuss that, so I think that's really good. And the other thing that I really like, remember, this is going to be more of a goal-oriented approach to getting people to have behavior changes, because these people come into your office at different levels of behavior change. Some people don't want to change, some people do.
Yeah.
Giving them something to do for the next visit is really, really important. It can be simple, or it could be just take pictures of your workstation and bring them in next time. Or by next week, I want you to do this, this, and this, and I'm going to test you on those things, and we'll see how you're doing with them. Just giving them something to go back, practice, and come back to you with. I think that's big.
I'm going to ask you, what do you think's most important in terms of keeping an engagement with the patient? Oops, sorry.
Well, one thing that I think is important is to find maybe a communication balance. So
Ooh, that's a nice term.
I guess.
Communication balance.
So basically being able to, like Brian said, educate them with what you want and how that's going to help with getting them to their goals, and then also discussing with them, how they think that they can get there. because oftentimes that's not necessarily a step that they've taken. I think that a lot of times in our society, sadly, we've been given a lot of passive treatments,
Yeah.
whether that's medication or whether that's just feel good, like a hot pack or a cold pack.
Right.
They're passive, and so that's where you really draw them in by trying to take in that locus of control, that
Right.
ability to really empower themselves
Absolutely.
and then push forward. So it's kind of that balance, and then reminding them from time to time why they're doing this. So something may be uncomfortable or something may be difficult or discouraging, but you tell them at the end of the day, look, this is your goal, this is why you're here.
So
you know?
focusing back on their goal,
Mm-hmm.
right? Not necessarily your goal. This is going to make you feel better. That may be your goal. This is going to give your range of motion better. But really, you want to be able to play with your children.
Exactly.
Yeah, okay.
Exactly. So if you want to get to this step, you
Yeah.
have to do this. And I'll give you the tools, but you have to go home and do it.
Right.
And that's a really clear message you have to say, like, look, you're going to be with me for maybe an hour a week, 2 hours a week.
Right.
It doesn't match what you're doing the rest of 24/7.
Right.
And so, yeah, I think it's just kind of that bounce back and forth and making sure that you're understanding where they are in that program.
Yeah. What was the term you said? Communicational balance.
Yeah.
I love it. Okay. I'm going to end on that with this. So.